Good morning, good afternoon, good night to wherever you may be tuning in from. Welcome to the Empower Her, the podcast. No, Empower the Patient podcast. There we go. Sorry. This is a podcast series highlighting the accomplishments and attitudes of changemakers advancing women's health and empowerment across Los Angeles County. Today, for episode 3, I have a very, very, very beloved special guest. We have Dr. Sanello. She is going to be a board certified specialist specifically in emergency medicine with a subspecialty in emergency medical services. She practices at Torrance Memorial Medical Center. And she completed her residency and fellowship at UCLA, so she's very involved in the LA County and has a very good understanding of pre-hospital care field operations specifically. So before going into the hospital in the actual site, and system level emergency response as well. She currently serves as the medical director for the base station at the Torrance Memorial Hospital, but she's had previous experience as a medical director at the Compton Fire Department from 2019 to 2022 during the COVID pandemic, which is, I'm just realizing that now. That must have been like a very immersive experience on top of being a medical director. So, anyways, just hopping into the first question, Dr. Sanello, what practices help you stay grounded as a provider while delivering sensitive, trauma-informed care for vulnerable women, especially?
Well, thank you first, Caitlin, for having me on today. This is wonderful to be here. So, thinking about this question, what practices help me stay grounded? So, I think the most important point is being in the moment. So, what do I mean by that? A career in medicine in general, particularly in emergency medicine, it's a marathon. And so you want to find a way to be there for your patients, particularly in these sensitive situations. In this situation, women that might be dealing with trauma, whether that's abuse, whether that is a reproductive issue, whether that is, concern for trafficking. When we have a brief time with these patients, in the emergency department, average patients like a 15 to 20-minute face-to-face time for the patient. And so that's very brief. However, this may be the only medical interaction that this person has with the medical community. So we want it to count. So be in the moment. So that means for these patients, sometimes I don't know when I walk in the room, it is one of these patients, right? But you
Right.
always want to have that consideration because if you don't consider it, you don't diagnose it or you don't um, give these patients the proper resources and care. So sitting down is the first thing. If you can sit next to the patient, whether that is on a chair or a stool, or if you don't have that because we're living in a time of very tight beds, squatting so that you're at their eye level helps with that communication. It makes it feel like you're actually there longer. It helps you perceive body language better, and it helps put these patients that could be very vulnerable at ease. Um, and we want to, try to engage our empathy in this moment and be there for this individual fully in that 15 to 20 minutes. Try not to think about the next patient to see. Try not to think about what's going on, outside
That
the
is
emergency
true.
department.
Hmm.
hmm So that can be hard to do, but these patients deserve that. But to stay grounded and to help with the next patient that's in the next room, you want to sort of take a deep breath when you're leaving the room and give the next patient the same courtesy that you just did to this individual. And so be in the moment. Be in the moment when you're at home. Don't pull a lot of these hardships home with you because that's how you get burnt out. So
Exactly.
having yeah
So I
having
think
that
like the
mhm.
main theme that you were communicating to is consistency. Like you have to quite literally learn how to reset with anyone that you interact, especially for the first time. I think of like the reason why I'm so enticed to ER medicine is because as the ER physician, you're almost like the scaffold for how their case is going to be unfolded pretty much. Like the scaffold as in like you kind of like hold that you like scaffold everything in terms of bringing in a social worker or telling a nurse to run all these tests and then telling all these techs to do whatever. And then that kind of really determines how they get admitted with a very strategic case on how they get admitted into a hospital. Because sometimes it's hard to build a specific case when someone has such a complex med history too. So I think that's why I'm so like much falling in love with ER medicine. It's just the little amount of time you have to interact with the patient to be able to do all that. Like it really takes a certain type of person to be that fast paced of a worker. And I feel like watching you in your practice, like very much rubbed off on me in a good way, seeing how being an ER physician specifically can really be super impactful for how a patient's health journey is going to be, whether they get
Hmm.
discharged or whether they get into the hospital or not. So,
Hmm. Yeah, you want to try to make a good foundation or scaffolding, as you said, for them so that their care can be built upon correctly or as best as possible.
no, yeah. And then that actually leads into my next question. So, I guess like what are the biggest challenges, especially when this is before we go to the ER, so from the field to hospital communication, and how can strengthening these like communication errors or those links improve patient outcomes when they are actually within the facility?
Hmm. So yeah, we're this is a continuity of care, right? From pre-hospital to the emergency department, whether they get discharged home or admitted to the hospital, we want that care to be as smooth as possible.
Hmm.
And I think having a good relationship with the pre-hospital care providers is the first step to providing that good continuity of care.
Mm,
And I think one thing that we need to keep in mind in the emergency department is that these pre-hospital providers have a very different practice environment than we do. Um, they're seeing their patients on the patient's home turf or in the environment that is not controlled, right? Versus they bring them to us and we're seeing them on our home turf, right? In an environment that we are controlling. And so that's very different. And their care can be a lot more complicated by those environmental possible hardships that are around them, whether that's not a safe environment, whether that, is a dirty environment. And they also see how the patient's living and see some social stressors that we may not. So always good idea to do ride-alongs with the pre-hospital care providers to allow for that sort of knowledge and that understanding to help strengthen the bond between us, which with a good understanding and a good sort of foundation in that respect helps with communication.
I see. That does make a lot of sense with the ride-alongs. Is there any kind of anecdote that you could think of right off the bat? I noticed that you did serve during the pandemic too, and obviously our operations are going to be a little bit reduced during the pandemic. I remember when I was at Torrance Memorial and it was such a ghost town, but yeah, do you have anything to share regarding, I guess, just specifically during that kind of turbulent time?
I, you know, everyone was, especially at the beginning of the pandemic, we didn't really know how things were spread and the correct PPI or protective equipment that we needed.
Yeah.
And so the unknown was sort of likely amplified in that pre-hospital setting because they don't have that stability of the emergency department. They're inside this home with, surfaces that haven't been cleaned and we were so low on masks and gloves and all of these things that it was a stressful environment for the pre-hospital care providers, EMTs and paramedics alike. And so it was interesting to try to you know help with those certain difficulties while the hospitals were helping or were struggling with these lack of resources. They were almost in a worse position than we were. So yeah, it was an interesting bonding experience and uh, sort of allowed sort of a stronger relationship, I think, because we went through that together.
So I guess like a follow-up question is like what would you say to your team that you were working with at the fire department now that we're kind of past the pandemic and it's calmed down a bit now?
Um, taking a step back, proud of everybody for working at a time that was, a lot of unknowns, and putting themselves at risk,
Hmm.
even though we didn't, know the details in terms of how it was transmitted, and that is, I mean, they put themselves at risk every time by going into an unknown house, right?
Right.
They don't quite know what they're going to meet,
Mm,
and then just this added to that complexity. So proud of them.
that's great. I asked that because a lot of people my age, like their 20s or maybe like as young as 18, they want to train as EMTs. So I feel like getting that kind of exposure from a physician's point of view is really interesting too, especially if I just remember specifically like at Torrance Memorial, at least with the volunteer program, the younger crowds, like the high schoolers, were actually the only branch of the volunteers that was allowed to stay, while
Hmm.
everyone else was, yeah, I guess like not dismissed, but they had to take a mandatory leave of absence because they were at risk for
Hmm.
COVID. So I just
Mm-hmm.
thought it was really interesting. I guess like being able to work with like a younger crowd or like let's say like maybe like middle age too that they weren't immunocompromised
Yeah.
population. So yeah, just like asking that just because I just remember that and I remember just not being able to fully understand what was going on in the ICU and stuff and
Mm-hmm.
yeah, it was really interesting. But going on to my next question, though, going back to the emergency care system, so away from the field site, what do you believe that female patients in specific need the most from emergency care systems?
So, going back a little bit from the first question,
Hmm.
is in order to make that 15 to 20 minutes count for these patient populations, again, you want to be in the moment and want to try to, think about what could this person be going through that brought them to the emergency department, right? They coming in for foot pain. But why are they coming in for foot pain like 3 times in a month, right? What are we missing? Or chest pain when they're completely healthy and young.
Hmm.
So you want to try to think a little bit outside the box and a little bit beyond their initial complaint, and see, is there something else going on? Like, are you having chest pain because you're feeling anxious because something else is happening in your life? So taking care of their medical needs. But when you confirm, like, okay, medically things are stable or safe, is there something else going on that brought them to the emergency department? I think that is sort of a skill that happens with time. And you think, okay, well, yeah, I took care of your chest pain 2 times previously, but yet you're here again. Like, what
Hmm.
else is going on? And um, because again, we may be the only medical system that they see in their lives or in their recent, situation, and
Right. As
we want to
primary care. Yeah.
try to catch some of these things. Like, okay, maybe I'm a little concerned about there's an individual with them. This sort of seems like a weird relationship. Are they abusive? Or are we concerned about trafficking? Having a system with your nurses to be like, okay, let's go to the bathroom, figure out how to separate them so you talk to them individually and not with
Oh, I see.
that person there. And having, a, with your social worker, having resources set up that you can provide the patient in a way that may be perhaps discreet. So if there's an individual with them that you're concerned about, like, pass it to them in the bathroom, for example, find a way to get them as much help as you can provide in that short period of time. No, let them know they're not alone and that they could come back and reach out for help, and sort of the next step in how they can do that. I think that is one thing that we can do to help them, even if it's not necessarily medical. A lot of these are sort of a social cries for help.
That's true. I was also going to ask, like, being a female provider yourself, have you ever encountered any patients that are very adamant about who attends to their care in terms of gender? Because sometimes I do see that a lot in labor and delivery units. There's like a sign that says female provider only because, I mean, they all have like different reasons, but I guess like when you are seeing a patient that might be admitted in that unit, particularly. maybe for antepartum or they're in labor or some other kind of issue. Have you ever
Mhm.
experienced that as a female provider yourself?
Yeah, absolutely. Especially, a younger individual, particularly, a younger female
Hmm.
that hasn't had an experience of going through a pelvic exam or having,
Hmm.
a female GU or gynecologic issue, and then this is their first time. It's a experience that they feel more comfortable sometimes with a female. And so we do the best to accommodate them. That's not always possible because sometimes there's only male providers on.
Yeah.
um, you know, Religion and religious beliefs could, signify that a male can't see them without,
Mm.
certain coverings on. So we try to accommodate that as best as possible and respect their wishes. On the flip side, I've had, men, assume that I'm the female and that I'm not a doctor. But luckily, women that have come ahead of me have fought that battle very well. And while that still happens, it doesn't really bother me as much. And just sort of educate them and move on.
No, yeah, that's great. Well, thank you so much. That's pretty much all the questions I had, but I really just wanted to just get more, I guess, be more educated, especially I was not too familiar with the field to hospital side of things, just because yeah, I never really thought to even shadow in terms of ride-alongs, but I think that would be like a really good perspective to see that side of emergency medicine too, because often like I feel like that may be like one of the most important modes of communication aside from the ER physician themselves. So I didn't even think about whoever tells them the information beforehand. It's like that send off from their home when they call 911 or anything like that too. So
Mm-hmm.
thank you for those insights. And that is pretty much it. Thank you guys so much for listening in on our third episodes. I titled it At the Front Lines Emergency Medicine and Resilience because Dr. Sanello does demonstrate that very well. And I have had the great privilege of seeing her practice too at Torrance Memorial. And yes, thank you so much for your time.
Thanks for having me.
Yeah, thank you. Have a great day.
Bye. Take care.
Thank you, everyone, for listening in on Empower the Patient. Sorry about butchering the title in the first place. So, just to conclude, we are a podcast series highlighting the accomplishments, attitudes of these change makers advancing women's health, especially in Los Angeles. We got to talk a lot about many different things, especially field to hospital communication, especially how that was really shaped by the COVID pandemic too, learning to always just be grounded and be in the present when you are, especially seeing patients at their most vulnerable times in the ER room. And so, again, thank you so much for listening in, and we shall see you next time.